Hello, I'm Dr. Radhakrishna. This is my assignment on rheumatoid arthritis. Uh, the assignment is based on a subject of choice. It's a choice of gastrointestinal or respiratory or immune, diabetes, endocrine, cancer, mental disease that I'm interested in, and explain the epidemiological aspects of the disease. The second point is to discuss the cellular and molecular pathways of this disease. The third point is to discuss the current technology, methodology used to identify new molecular targets and develop new treatment. And uh, the fourth point is they identify the research gap of this disease. What's the important aspect yet to be studied? The fifth point is propose a research to address the research gap mentioned above or by me and explain the rationale. My subject of choice is rheumatoid arthritis, which I have been learning about it and training doctors into this field. Rheumatoid arthritis is a chronic inflammatory autoimmune diseases that initially affects the small joints and then spread to the bigger joints. It also affects other organs of the body, such as the lung, the eyes, the kidney, heart, skin. And in rheumatoid arthritis, there's a destruction of cartilage, joints, and the ligaments, and the tendons become very brittle. The damage to the joints lead to abnormality and bone destruction, which is may be quite painful for the patients. The epidemiological of rheumatoid arthritis in Malaysia, if you look at the age group at the bottom here, between 15 to 24, 25 to 34, 35 to 44, and 45 to 54, and this range of age range group, if you find that most of them are maximum of them are between 35 to 54. This is the middle age group. And the females outnumber the males in the epidemiology. In the worldwide epidemiology too, we can look at the age groups between 45, 40, 45 to age of almost 70, 75, and the, the this is the range where most of the people are prone for rheumatoid arthritis, and the females outnumbering the male population in terms of the epidemiology. The overview and objective to study the depth of the molecular and cellular pathways and newer molecular targets development of new treatment. Under the category of molecular and cellular pathways, you have the genetic factors affecting the rheumatoid arthritis. Most of the genetic factors are generally related to the HLA, PADI, PT, PN22, CLA4, TRAF. Basically, it basically means that the human leukocyte antigen and strongly associated with rheumatoid arthritis, specifically the allies within the HLA or DRB1 gene, and they are pear-shaped epitome and is linked to increased risk of rheumatoid arthritis. The individuals carries these epitome allies like such as 010, 012, 0401, 0404, 0405, 0408, 100, 1402, and others may be increased risk of rheumatoid arthritis. However, the presence of allies is not a definitive predictor, as many rheumatoid arthritis patients do not have them. Not everyone with these allies develop rheumatoid arthritis. There's an interplay between the genetics and the environmental factors which contributing to the nature of development of rheumatoid arthritis and progression. PADI, or also known as peptidyl arginase deaminase enzyme, particularly PADI 4, and they are implicated in rheumatoid arthritis. Other PADI enzymes are catalyzation of catalyzed citrullization process, where the arginine is converted to citrulline into a protein. In rheumatoid arthritis, abnormal citrullization is observed, leading to a production of autoantibodies like anti-citrullinated proteins antibodies, or ACE PA. And this is a test that we can do very early to determine a person is having prone for rheumatoid arthritis. PADI4 gene variant is also associated with increased risk of rheumatoid arthritis. Citrullination is linked to synovial inflammation in joints. Detection of PAS is used in rheumatoid arthritis diagnosis and understanding. And PADI's role has influenced the development of targeted therapies for diseases, while PADI and citrullination contribute to rheumatoid arthritis disease complexity involving various genes and environmental factors. There's an interplay between these two, genetics and environmental factors. While the PTN22 gene, specifically it's the gene variant of R620W, has been associated with increased risk of rheumatoid arthritis. PTPN22 encodes a protein tyrosine phosphatase involved in the immune system regulation. The R6220W variant is thought to be thought to disrupt the regulatory function, contributes to the altered immune responses, and highly susceptible to autoimmune, including rheumatoid arthritis. While individuals carrying this variant have elevated risk of rheumatoid arthritis, and is not a sole determinant, and the complex interplay again between the genetics and environmental factor, which may be triggering the influence and the onset or the progression of the disease. While the CTLA4, that is a cytotoxic T lymphocyte associated protein or 4-CTLA4 is a key player in the immune regulation and genetic variation in its gene, contributing to the development of autoimmune diseases like rheumatoid arthritis. The tumor necrotic factor or TNF receptor associated factor or TRAF1 is a gene that's implicated in the genetic susceptibility of rheumatoid arthritis. The immune system stimulation and rheumatoid arthritis actually are divided into two sections, the central tolerance and the peripheral tolerance. The central tolerance is distinguishes the virus and the microbes and many other factors. The peripheral tolerance is basically its immune peripheral like T cells, T regulator cells, and CD4. Environmental factors and rheumatoid arthritis, especially related to smoking and the molecular changes and the cellular pathways. Smoking from cigarettes contain toxic metals like lead, cadmium, arsenic, mercury. They trigger cellular reaction, and the main cells executing the bone and the cartilage destructions are the osteoclasts and the fibroblasts like synoviocytes, and it influences the immune cells. And it also triggers the inflammatory cytokines, and which causes structural damage. And this immune pathway involves the T cells, B cells, dendritic cells, macrophages, neutrophils, non-immune like fibroblasts, chondrocyte cells. The participation of the secretion of many pro-cytokines, chemokines, proteases like MMPAS, ADAMS, and other matrix lysing enzymes that disturbs the immune balance, leading to cartilage and the bone damage. At this early stage, it is best to do a cytokine panel so we can be able to see some of the cytokines like interleukin 1B, interleukin 6, tumor necrotic factor. Smoking also causes nanoparticles to be breathed along with the tobacco smoke, which activate PAD2 or phosphodiol arginine deaminase, and the PAD4 inside the cell. Smoke affects the cells, including the upgrade of PAD2 expression and subsequent citrullination. Periodontitis and the rheumatoid arthritis relationship. The Pyomonas gingivitis or Aggregatibacter acetomycetemens microbiological candidates involved in rheumatoid arthritis pathogenesis because they produce a citrullized antigens, and these antigens in the P. gingivitis secretes phosphodiamine deaminase or PAD-like enzymes, and these enzymes are responsible for generating citrullized proteins major targets is the autoantibodies in rheumatoid arthritis. So this periodontitis drives rheumatoid arthritis production of citrullinated antigens by the P. gingivitis. The relationship of gut microbiome and rheumatoid arthritis. Recent studies indicated that the pathogenesis of rheumatoid arthritis requires the interaction of genetic and environmental factors. This is very crucial, such as gut microbiome. The pathogenesis requires interaction of genetic and environmental like gut microbe. The lower this particular group of bacteria called Cutes and bacteriocytes ratio in the gut microbiome. The taxonomic analysis of bacteroids, parabacteroids, paraprevotilla, and many other bacteria enriches the gut in the rheumatoid arthritis patient. And While the butyrate producing, which is the butyrate is a food for the bacteria, like fecal bacterium, Rosa, Bura, and many others are depleted in the rheumatoid arthritis, but they're enriched in healthy individuals. That indicates that this particular bacteria is important in the prevention of rheumatoid arthritis. Dust exposure and rheumatoid arthritis. Several components, including the silica dust, has been linked to a systemic autoimmunity and the systemic autoimmune diseases. They trigger silicon exposure can trigger immune response, and it can be tested using the anti-cyclic citrullinated peptide antibodies. Several viruses have been meta-analyzed, and they have found to be linked up to the trigger of rheumatoid arthritis, like PBV19, EBV, or Epstein-Barr virus, cytomegalovirus, HBV virus, HCEV virus, uh, VZV, and rubella virus trigger rheumatoid arthritis. There are five postulated mechanisms involving the development of rheumatoid arthritis. They also include molecular mimicry, the epitome spread, the beta cell mediated pathways, bystander activation, and the supra antigens. The epigenetic modifications and rheumatoid arthritis relationship. There are factors which can cause transcription changes or expression of genes through histones, because the histones are locked around the chromosomes, so they can be triggered by either external factors or internal factors. These triggers can trigger erasers, writers of the histones. So the protein post translation modifications through processes due to these epigenetic influences like acylation, carbomylation, citrullinarization, methylation, phosphorylation, and sumolation and ubiquitinations. These can influence the histones through the influences from outside. In the loss of tolerance phases, there's a cellular and molecular pathways are involved. There are multiple environmental factors like smoking, pollutants, microbes, before crossing into the threshold to trigger diseases in the genetically vulnerable people. Second will be the dendritic cells presenting altered self or related peptides to T cells breakdown of tolerance mechanism, leading to activation of T and B cells, effectuating the synthesis of cytokines and auto antibodies. This picture shows the position of the bone and the cartilage, and bone below the cartilage in between, and then there's a synovial fluid. And we can actually clearly see that in between these two cartilages, we have a complement triggering and activated like C3 and C5a. And we also see a lot of other cytokines pathways or inflammatory pathways like arachidonic acid triggering the PGE2, TGF, or TGF. And if you look at the other pathways, it also triggers the mast cells, tumor necrotic factors, interleukin 1. To illustrate, this is an illustration of what exactly happens in the joint. So what are the immune cells involved in the rheumatoid arthritis? We have to go back to the time of asymptomatic synovitis, which is the first step of the changes in the synovial hyperplasia, and the cells involved are the platelet-derived growth factors like PDGF, and the transforming growth factor beta is TGF beta. The next stage is the infiltration of the immune cells. These immune cells infiltration by dendritic cells, T cells, B cells, plasma cells, neutrophils, macrophages, mast cells, natural killer cells. And there's a secretion of inflammatory cytokines and the chemokines, and the increase in the cells like interleukin 1, tumor necrotic factor alpha, GM, GCE, GSE, interferon Y, gamma, interleukin 6, interleukin 15, interleukin 16, interleukin 17, interleukin 18, but there's a decrease in the interleukin 4, interleukin 10, interleukin 11, and interleukin 14. In this phase, there's a secretion of proteases, means the one that causes a destruction of the cartilage and the synovial part. It involves the matrix metalloproteinase 1 and disintegratin green and metalloproteinase with thrombospondin motifs, capsaicin K, capsaicin G, elastase, proteases. So when the subsequent progress of rheumatoid arthritis is a symptomatic arthritis, this is where you see massive amount of immune complexes causing arthralgia. In the knee joint, it has got cytokines, chemokines involving interleukin 1b, interleukin 6, interleukin 8, tumor necrotic factor, CC chemokines like CCL3, cysteine X, cysteine 1, GMF, CSF, they all cause inflammation and increased exudates. As the disease progresses, what happens within the knee joint is that there is a trigger of complement cascade system that involves C3, C5a affecting the macrophages, neutrophils causing to release tumor necrotic factor alpha, PGE2, that's prostaglandins, interleukin 1, COX2, and affecting the osteoclast of the bone. So as the inflammation exceeds, and then you'll have an established rheumatoid arthritis. In this phase, we'll find numerous immune cells, including cytokines, chemokines from mast cells, lymphocytes, macrophages, neutrophils, releasing tumor necrotic factor alpha, interleukin 1, interleukin 6, CCL2, CCL3, CCL4, MMPS, rank KL, affecting the osteoclast. The question is, has been asked is, what is the current technology or methodology used to identify newer molecular targets and the development of treatment? One of the ways that methodology used is genomic studies, where genome-wide association, or GWAS, analyzing the genetic variation in a large cohorts of rheumatoid arthritis to identify genetic factors associated with the disease. The next generation sequencing, examining the entire genome and the specific genes in depth to identify variations that may contribute to rheumatoid arthritis. The other one is the transcriptomics, where the RNA sequencing, profiling the entire transcriptome to understand the genetic expression patterns in the rheumatoid arthritis, helping to identify the dysregulated genes and the pathways. So micro array analysis, examining the gene expression levels on the genomics wide scale to identify the differential expression of the rheumatoid arthritis genes. For the proteomics, we use mass spectrometry to identify and to quantify the proteins in the synovial fluid, tissues, or the blood to discover proteins associated with rheumatoid arthritis pathology. Here, the protein microarrays, the high throughput screen of the proteins interacts and modification of to identify the potential targets. The next way of identifying our methodology is the immunology, where we use a flow cytometry or immunohistochemistry, where we characterization of the immune cell population is affected tissues to understand the immune response of rheumatoid arthritis. That also involves cytokine profiling to identify the dysregulated cytokines and signaling pathways involving in rheumatoid arthritis. This is a computational approach that bioinformatic and systemic uh, system biology. There's an integration of data of multiple sources to identify the potential molecular targets and understand the complex interaction underlying the rheumatoid arthritis. The network analysis or analyzing the molecular interaction of networks to identify the key nodes or potential targets. High output or drug discovery, high throughput screening or HTS, screening large compound libraries to identify the molecules, modulate specific targets and pathways relevant to rheumatoid arthritis. So structural biochemistry or structural biology, using structural information to design, optimize smaller molecules targeting specific proteins involving rheumatoid arthritis. The other methodology is the clinical trials data, analyzing data from the ongoing or completed clinical trials to identify the potential targets and assay the efficiency of novel therapies. The other methodology is translational precision medicine, the translocation of mechanism from research in the early clinical development forward translation bench to bait. The second methodology will be the back translation of the late clinical development insights to drug discoveries, reverse translation, back translation, bait to bench. The third methodology is data-driven mechanism indications pairing. And the fourth one will be the translocation of omics signature into clinical relevant biomarkers and endotypes. The fifth way is the development of patient-tailored companion diagnostic, precision medicine. These include multi-omics, biomarkers guided trial design, more model design based drug interaction, precision artificial intelligence, digital biomarkers, and patient engagement. Omics is a revolutionary field that includes detection of technologies for RNA, proteins, and molecules that are most proximally to the real-time pathophysiology and the alloreactivity as compared to genes. In a short time, the use of transcriptomics, proteomics, has led to identification of novel mechanism of allogenic HSCT or stem cells there, which are unlikely to be discovered in the traditional hypothesis-driven research. A promising proteomic approach is the use of protein biomarkers in the risk stratification to for better employ current diseases modalities. Furthermore, the biomarkers findings present in this chapter offers a potential for exploring targeted therapies. The one of the important question asked is the research gap of in these diseases. In these diseases, my study is basically on rheumatoid arthritis, which is the area of interest, and a question was asked which important aspect is yet to be studied, and here the research gap studies yet to be studied in detail. Here are the following ones. This is the first of the research gap, involves precision medicine and personalized therapies. These methods of personalized therapies or treatment are based on individual patient characteristics, which includes genetics, epigenetics, or biomarkers. Epigenetics is the influence on the genetic genes and the biomarkers involved. The other part of the research gap will be the understanding early disease mechanism, like at early molecular immunological investigations, leading to the development of rheumatoid arthritis to enable earlier diagnosis and intervention. One of the major areas of research gap is the microbiome biome and immune interactions. This is the major area to explore the role of gut microbiome and its interaction with the immune system in rheumatoid arthritis, pathology, pathogenesis, and progression. A promise of this method example is the treatment of using fecal microbiota transplant, which has been going on for many number of years. And this is the area of interest that helps to in the gap research. One of the missing component is the long-term outcomes and the quality of life. And we are so focused on the drugs and the development of drugs that we forget sometimes the quality of life, studying the physical and the mental health, and understanding the social and economic aspects of these diseases. Severe rheumatoid arthritis leads to debilitating consequences, and these will help the patient prepare earlier and in advanced stages of the rheumatoid arthritis. Biomarkers of the disease activity and progress. Most of the time, sometimes very early stages, you may get a seronegative of rheumatoid arthritis due to several other causative factors. So to identify these, we can identify reliable biomarkers accurately reflecting the disease activity, predicting long-term outcomes in the aid and monitoring the tailor-made treatment strategies. Specific biomarkers like tumor necrotic factor alpha interleukin 6, especially in the presence of seronegative rheumatoid arthritis conditions. Mechanisms of treatment resistance and the investigation of the mechanism underlying the treatment resistance in rheumatoid arthritis patients, or understanding the metabolic pathways in rheumatoid arthritis. These will help to improve the therapeutic approach and development of alternative interventions. Then there's a role of non-coding RNAs. The understanding the involvement of non-coding RNAs, such as microRNAs, long non-coding RNAs in the rheumatoid arthritis and its potential therapies as a therapeutic targets. The environmental triggers in the gap research plays a major role, exploring the impact of environmental factors such as lifestyle, diet, pollution, the development of and the exacerbation of rheumatoid arthritis. These trigger factors may be external and internal triggers, and they contribute to a massive inflammation process. The other research gap is the patient's engagement and the shared decision making. Enhancing the patient engagement in research and clinical decision making, including assessing the patient's preference, priorities in the treatment outcomes. There are patients who can't tolerate NSAID or disease-modifying anti-rheumatoid drugs or biologics because of serious side effects. This hesitation will help us make a decision along with the patient, and this is part of the research gap. The other of the research gap is the comparative effectiveness research. They're conducting more comparative effective research to evaluate real world performance of different treatment strategies, including traditional diseases modifying anti-rheumatoid drugs and biologics. There are pointers towards my interest into rheumatoid arthritis. The research gap into rheumatoid arthritis involve three factors. One is the lifestyle modification. The other is the removal of environmental factors or triggers. The third part will be the correcting the mitochondrial dysfunction. Lifestyle modifications is like teaching specific exercises, and food modifications like cutting down inflammatory food for the first 3 months is called um, autoimmune protocol, where we cut down all the inflammatory markers or inflammatory food, and we have either subjective uh, or investigative test to counter check these modifications. And We also cut down the any food that has a molecular mimicry that triggers the rheumatoid arthritis. And that removal actually reduces the amount of inflammation and the requirement of drugs to help the patient overcome the pain. The third factor will be correcting the mitochondrial dysfunction. This is based on 10,000 analysis that I have done personally past 10 years. And I have very specifically noticed mitochondrial dysfunction, and on correcting the mitochondrial dysfunction, we found the patient is able to overcome rheumatoid arthritis with a gradual reduction of the drugs. Uh, this mitochondrial dysfunction, I find is very interesting, and I've done blood tests based on cytokines with University Malaya independent studies on N equals to 1 research. So based on this, I am very interested to go into mitochondrial dysfunction related to rheumatoid arthritis in gap research. Over the past 10 years, managing numerous cases of rheumatoid arthritis, and I found uh, a lot of them are involved with cytokines, the massive amount of cytokines. So what I've done is I've taken 10 patients with rheumatoid arthritis definitive diagnosis, and on my own initiative, I've discussed with University Malaya Laboratory through a professor, and I've independently tested the blood over the 3 months before management and every month over the 3 months. And this was long before I signed up for master's program. And we have definite proof of cytokines improving, and the patient has improved symptomatically and able to cut down the medications based on the stages of the disease, whether it's early, stage 1, stage 2, stage 3, or stage 4 of rheumatoid arthritis. In stage 4, of course, surgical and medical correction comes in, but in stage 1, 2, and probably stage 3, I'm able to overcome rheumatoid arthritis. And based on these thousands of tests, I've developed a nutraceutical product called RK0, and uh, and I found it especially triggered and developed towards mitochondrial and cytokine panel reduction. The cytokine will be based on interleukin 1b, interleukin 6, interleukin tumor necrotic factor, and NK cells, and many other factors involved. I've sent blood tests, and I've seen definitively the patient's cytokines have come down over the 3 months. But currently, I've registered the product in Malaysia and Indonesia and India, and I'm expanding worldwide and including US under the category called GRAS in US is generally recommended as safe. And I suggest to have gap research done on cytokine panels or rheumatoid arthritis with the help of IMU guiding me, and with your guidance step by step how to write a protocol and the scientific explanation behind it, plus the investigative procedures before and after. And I think this is a very interesting concept. Currently, this product is sold in the open market by the thousands in Malaysia, and we have thousands of improvement. And similar experience, I have it in India, and thousands of patients in India have improved. And for that reason, I suggest that we do a scientific backing with IMU in the gap research. And I'm hoping seriously that this research can be done with the IMU. My idea of research with IMU is to develop a protocol of management rather than one singular approach like TMA, RDS, or biologic, which we can achieve the same recovery minus the side effects and the use of multiple drugs. So my research is currently on N equals to 1. Uh, Here's one of the patients who have improved tremendously on my independent research, and I've linked up a private YouTube of a patient. And in case you're not able to view it, you can please message me back. I can send you the video of a trials done independently. It's a symptomatic improvement. And The blood test also shows me that the patient has improved, reduced number of cytokines.
3 hari lepas ni sebenarnya saya sakit ni dah hampir start bulan 10, 10, 11, 12, 1, 2, 3, 4, dah hampir dekat 6, 7 bulan dah. Dan permulaan je dengan semua sakit lutut je. Nak pijak susah.
Assalamualaikum Afia.
Waalaikumsalam.
Okay, it's already 1 month since you took the RK0 for the research kan. So just tell me, how do you feel now?
Sekarang ni rasa ringan. Saya dah boleh duduk. Cuma tangan je tak boleh nak genggam lagi.
Okay.
Tapi progress dia as long dia boleh sit down lama lah.
Lama lah. Compared dengan dulu you were lying down.
Lying down, lepas tu dah boleh duduk dah. Lepas tu cuma ni lah.
Tak boleh gerak sangat.
Ni dan masih belum boleh berjalan dengan ni lah, tapi
You can stand up. Yeah, you can stand. Okay, that's good. Excellent. Alright. So you're going to continue taking the RK0 for another month now. Okay. We have sent 2 blood tests kan? Yeah. So thank you to Dr. Rada and his team ya. Okay.
Terima kasih Dr. Rada. Thank you for Dr. Adlina juga.
Okay. Bye bye. Thank you.